Hi everyone, this is Neel Raithatha, consultant audiologist and director of WAXscope. Thank you for joining me in my latest video using the WAXscope. And here we have a patient who attended with bilateral, fully occluding, really occluding and impacted earwax. And I'm just commencing with their left ear first. So this procedure was a bit more tricky than usual, primarily because they had very, very hairy ears. So the hairs in the ears are normally located on the outer third, the cartilaginous portion. And that's because on the cartilaginous portion of the ear canal, you've got 3 layers of skin. And it's the middle layer, the dermis layer, where you find the hair roots, the hair follicles. The inner 2/3 of the ear canal is osseous. It's made up of bone, where you only have the epidermis layer of the skin, the outer layer of skin. And when you've got loads of hairs like this, it can be tricky because it can obscure your view. Now, I've tried trimming them both manually and using electronic trimmer in the past with other patients. And because obviously these hairs are located inside the ear, it's very tricky to do that. I have previously also plucked some of the hairs. Now, this is where you get pros and cons with the endoscope and when you're using a specular. Now, if these hairs were kind of more on the lateral side, so of course, as I mentioned, they're only located or should be only located on the outer third, then a specular, which is what we're using at the moment with the WAXscope, is very useful because it helps to push the hairs out of the way. But when the hairs are a bit more located deeper in the ear, so obviously everyone's ear canal length varies. So 1/3 of the outer part of the ear canal can be longer in one patient than another. And sometimes with a specular, it just doesn't go into the ear deep enough. But it can also be if a patient's got a very narrow, bendy, twisty ear canal. So this patient's ear canal is slightly narrow. So when you've got hairs that are a bit deeper, it's sometimes difficult for the specular to push them out the way. And that's probably where an endoscope is more beneficial, because with the endoscope, you can, for deeper wax at least, you can insert the endoscope lens through the hairs to reach more medially located earwax. So earwax is that deeper into the ear canal. Conversely, when the wax is more near the entrance of the ear canal, then having a specular can actually be more beneficial because it can push those hairs out the way, whereas the endoscope can't, because you can't, if you push you can't push the endoscope past the hairs because there's wax in the way. So you get pros and cons. So the writer was actually more tricky. And that's the procedure I did first, but I'm just showing you the left one initially. So we used a combination of instruments, a curette, an ear hook and microsuction. You can see these hairs are just there and you can't push the speculum any deeper to push those hairs out the way, but we still could see the patient's eardrum. They've got some superficial otitis externa, some very dry flaky skin. So this is their right side and you can just see how embedded, impacted this wax is. It's solid and it's adhered to the canal wall. It's a very dry skin, so they have got superficial otitis externa here. In this case, once I removed the main blockage, there's a bit of wax, a dry skin on the eardrum, which I removed using the zoom functionality, so do stay tuned for that. And I don't know whether you just noticed that this wax is so adhered to the canal wall, when I was wriggling like I am now, the whole ear was moving alongside with it. So it's almost become part of the fixtures and fittings of this ear canal, this wax. So it has been there for a while. I just installed some medical grade olive oil spray to see if I can help soften this, break down the adhesions around the edge. You see I'm going all the way around the edge with the suction probe, but this is not budging with suction at this stage, so I'm going to revert to the curette and the ear hook in a moment. So I'm just going to the top of the plug. I think I initially used a curette, but it just wasn't suitable for it, so I did then revert back to the ear hook. It's so dense that you just can't penetrate the curette into it. So I'm trying to submerge it or get really around it, but this plug is quite a long plug, so it extends towards the eardrum. Now, it did move forward slightly there. See all those hairs. So again, I can just insert the hook over. I'm trying to penetrate the tip of the hook into this, and it was so hard at first that the hook went around it, but then I managed to embed it, and that's the benefit of the right angled ear hook. The hook is a bit more tapered, the tip, so you can penetrate into this wax. If I was using a traditional ear hook, I probably wouldn't have been able to embed it because it's a bit more blunt at the tip. So extracted the first piece. You can see all this wax and skin, it's matted with these hairs. We can just see the short process of the hammer bone, the malleus just over there. So I've created a gap so the patient can hear better. Now I'm just trying to go in again. You see, I'm trying to embed this tip in, but it's such a solid piece. But I managed to get in and behind. I'm slowly bringing it forwards. Well, there, I almost chiseled it because it's so rock solid. And you can normally tell by the appearance how hard wax is. You can see this is glistening. So, and it's got loads of hairs, so it's a telltale sign that it's a solid boulder. So I've just gone back to microsuction for a moment. Now this plug is quite deep now, in the probably the inner third perhaps. So again, I just want to go over and behind. And just, yeah, see, I managed to get it behind it and into it, and I'm bringing it forwards. So although it's not come out yet, it is coming forwards laterally, so I am transporting it near to the entrance of the ear. So I'm going to go in again. And it is like a boulder. Now I've managed to, I think I've got some penetration here, so slowly coming forwards. So this is a case where traditional microsuction alone is just not, in both ears as well, it's just not going to do the job. So you're going to have to, if specialists are not using manual instruments, then this patient would be sent away to use drops for several weeks, I would think, before it's even soft enough to contemplate microsuction. So this is where using manual instruments when necessary is really important. So see, they've got really hairy ears, and again, these hairs are quite deep. Now, I've managed to push the speculum in a bit deeper on this side, so we can push some of the hairs, the majority, out of the way. We've just got some flakes of dead skin, which we're going to remove. There's one on the eardrum there. There's one in the anterior recess where I use the zoom, and there's one a bit more midsection of the canal. So we're going to get this deep a bit. So I'm just pushing the speculum in a bit deeper, so I can push as many hairs out of the way as possible. So managed to get that piece away. I think we're going to go for this midsection, so we're just going to get that in focus. And I do recollect, once we finished the procedure with this, these skin and wax plugs, I dropped it on my medical trolley and it really pinged, so it just gave the patient an idea of how hard it was. So initially, I'm doing this without the zoom, but I'm going to stop. I'm going to zoom in. There we are. And it just made so much more of a difference. Especially because the ears are quite hairy, so we've got a good view there. Just managed to pull that away. So just going to re-examine the patient's ear. Again, they've got this superficial otitis externa. So this, I think this plug was actually adhered to the canal wall. As you can see where it was attached, it's a bit flaky. But yeah, so these are the more tricky procedures when you've got patients with hairs that are a bit deeper in the ear canal where the speculum can't push them out of the way. Well, I hope you enjoyed that video, guys. Take care, keep well, speak soon. Bye.